So I'm going to talk about registries and how they impact. Although I'm going to be looking at this from a clinician's perspective, please understand that's the topic I was assigned. What I'm going to show you is impacts that affect 5 arenas. And the easiest thing to remember is the 5 Ps. For startup companies, they have it down to 3, but for physicians, it's 5. The patient is number 1, the physician is number 2. That's the hierarchical of our historical relationship. The payer is number 3, or as the Canadians say, the payee, but the payer is number 3. And you can also substitute that for a purchaser, a Microsoft, an Amazon, a Boeing, Costco that purchase healthcare for their employees. And then you have product and device manufacturers. You can also put pharma in there. And then lastly, policy makers. So when you look at registries, you can see them as prospective observational data platforms, different from a randomized controlled trial. And you can have them disease specific. The thing that so you can have a joint replacement registry, you can have a spine registry, you can have a vertebral compression fracture registry. The great thing about registries is they put the understanding of medicine in the proper order. You look at the entire population, that's the heterogeneity of disease. Everybody who's got a bad hip or has got a bad spine or has got a vertebral compression fracture or has osteoporosis, so everybody. And you gather data on all of them, and then you look at the heterogeneity of treatment, all of the different ways your colleagues take care of the problem. And I don't care if they take care of it in a hospital, in a fluoroscopy suite, in their office, in an ambulatory surgery center, or in a broom closet on the top of the building. I don't care, as long as everybody gets measured by the same yardstick. And those are the outcomes, the pain, the function, the return to work. Everybody gets measured by the same yardstick. Because the advantage of doing that is it allows you access to the healthcare utilization costs. And that's where you answer the value equation. The value equation doesn't occur in any of those colors other than the orange color. And when you're answering the value equation, you're answering for the people who are the purchasers or the payers. And you can look at how much does it cost to do an ASC hip replacement, an ASC disc replacement, a vertebral augmentation for a patient with osteoporosis. And you can look at the different sites of care and you can see where the savings are. And that's where population medicine wants to go. Let's see if I can do this. Nope, it's up to you, Linda. So when you take a look at this, the value is always for the individual who's trying to ask the equation. So here I'm putting the patient as the person asking the value. You know, when I send my kids to school, what's the value of that school? When I purchase a home, what's the value of that home? And you're looking at cost and quality. And for us as physicians, that's your risk stratification. And when you're looking for how long does that benefit last, that's your surveillance. But, you know, is it 1 year you're going to measure? Is it 2 years? Is it 5 years? Next, please, Linda. So what you need to understand about registries is they are not research. They're quality improvement. So if you're doing an arthroscopic ACL and you're using a Marcaine or a REC concoction, or you're using Exparel, those are just different ways of doing the same procedure. As long as you're using the same metrics, what's the 24-hour pain relief? What's the 3-day pain relief? What's the 10-day opioid use? The same way that Boeing looks at, well, Boeing's tough right now, but Boeing looks at aircraft control mechanisms, or Toyota looks at producing a pickup truck exactly the same. These are quality improvement. They're not research. And you may find small sub-cohorts within that in which you can do a randomized controlled trial, and you already know how many patients are in that group. It's a beautiful way to improve your practice, and that's what I'm gonna show you. Next slide is ways that you improve your practice that improve your revenue. And the way that registries work is they use the same yardstick and they put benchmarks on it: top third, middle third, bottom third. They focus on patient-reported outcomes because that's what matters, not how satisfying the surgery was for you, but how quickly did the patient return to work? How little pain did they suffer? How rapid was their improvement in their function? You can look at the process of care for efficiencies, but in the end, the benchmarking is going to show you the lowest cost avenue that maintains an equivalent beneficial outcome. Next slide, please. That's why it's quality improvement. So now let's look at the rewards of these 5 Ps. And next slide. So the first thing we're going to look at is the 5 Ps, and there they are on the left. Next slide, please. Now I'm going to speak from a payer perspective. So these are slides from the spine fusion registry that Jens and I and Dave Flum put together, but this is the state of Washington saving $83 million. And notice that the slope of the cost curve for the Scope hospital, the Orange hospital, is flatter, and the overall costs are flatter. So you are helping a payer with an annual savings, and that's just from the enrolled hospitals. If all of the hospitals were enrolled, the savings is much greater. So this is population health on an economic scale. Next slide, please. Same goes for, I didn't show Medicare, but next slide, Linda. Oh, here we go with Medicare. Now this was what changed. It's not the benefit to the patient, it's the cost. So here you're looking at vertebral augmentation. So little old ladies with osteoporosis, vertebral compression fractures, if they come into my clinic on day 1, they only have 3 images, an injury image, X-ray, an injury MRI, and then a follow-up image post-cement augmentation. And notice how dysfunctional they are. The Roland Morris scale goes to 24, and at 24, you're hospice bedridden in agonal breathing, and they're at 20. So they can't get out of the house, they can't get dressed, they need someone to help them with their home. Their pain severity on a 0 to 10 scale is 8 out of 10. So they are horribly painful. And if I operate on them, their pain scale goes from 8 to 1. Now, an 85-year-old woman with a pain level of 1 is dancing on the table. She's taken out her grandkids to the beach. They're walking and doing everything they want. And a functional change from 20, Roland Morris change from 20 to 6 or to 3 is a 6-fold MSID, the minimal important clinical difference. And if you look at the delay of 6 months, they still are horribly painful. They're still badly dysfunctional. They still have a 2 to 3-fold MSID change, but you just spent 3 times as much money, caused 6 months of agony to get the same outcome. So when I testified before the Medicare administrative contractors and showed them these slides, they immediately changed their authorization process and ceased any delay in the patient's care because it was coming out of their budget. I was still getting good outcomes. Patients were still coming to me, but it was coming out of their budget. Next slide, please. So here are the payer benefits. So it's very important to represent that. One more forward. So when you look at the rewards of this kind of work, you have rewards to the patient. They get immediate pain relief. You have rewards to the physician. The procedure was done efficiently and the patient enormously benefited, and you were able to do that in a very efficient manner without a bunch of authorization. When you look at how it rewards you financially, your reimbursement tripled. So if you compare the Medicare reimbursements associated with this during the restriction phase, the reimbursements for a procedure that takes me roughly 17 minutes is comparable to a joint replacement or a disc replacement. Next slide, please. So the physician benefits, but I didn't want to focus on that so much. Here you see hospital health system benefits based on cohorts. And for those of you who are involved in navigating bundles. These are what are called bundle busters. If you are not doing this kind of analytics for your outcomes, you're going to end up at risk for significant costs. And these really are adverse events coming through the ER. These are readmits, these are take back to the operating room. And you see that enrolling in a registry drops all of those lines. And they get down into areas where you can budget these bundle busters. They will occur, but at least you can budget and you can get secondary insurance for them. Next slide, please. So if you were to do this globally, you're talking about taking care, in this case, I'm looking at osteoporosis, you're talking about taking care of half of the world's population. 20% of elderly women will come down with osteoporosis and its associated hip, knee, spine, wrist fractures, the fragility fracture condition. And if these people are not treated, and what we've seen in the analytics of the vertebral compression fracture group and the data you see on death, debility, and destitution comes from the hip fracture group, there are consequent deaths to the delay in care. Next slide, please. So the vertebral compression fracture data that I showed you, the healthcare utilization data, we're in the process of exporting globally so that we can reach more women with this more quickly. Next slide, please. The thing about Registry is it gives you data that you can use in your practice. It helps you improve the quality of the care that you deliver. It's quality improvement, it's not research. And it's a collaboration that requires you think of other people's interests equal to your interests and put other people first. And when you put other people first, you end up with an enormous trust that the things that you say and the data that you show are trusted. And that helps make change. And that's it for me. Thanks.
Outstanding. Thank you so much. And congratulations on your accomplishments also. Just two quick questions before we move on to our honorary featured speaker from the East Coast, Dr. Cates. How much does it cost per capita to kind of get registry data per visit per patient? And does an EMR, an integrated EMR with automated PRO gathering help, or is it kind of just still up to you to make sure that the data is entered?
Okay, so for the Medicare piece, Medicare came to us, or the Medicare administrative contractor out west of the Mississippi, it's called Meridian. Palmetto and others are east and south. And the physicians paid for it, and it was manual abstraction. Don't ever do that. But it was $125 per patient to accomplish this. And with the digitization, which we are now doing, so machine learning for unstructured and for structured data, the cost will be less than a third of that. And the ballpark figure is it'll be somewhere around $25 per patient.
Super. All right. Thank you. And I hope that you'll be available as a resource for others. We have several colleagues from several facilities on the line here tonight in terms of how to replicate your success model for other specialties in orthopedics.
Yeah, and the good news for all you younger folks, these tools that we are developing, the digital tools, the machine tools, the AI tools, they are so much more accurate. Human abstraction is just frighteningly inadequate. And the completeness percentage is in the 98, 99%. And it's so encouraging. Your practices are going to be marvelous. And you're going to love the data that you see. It'll be yours, and it'll be compared to anonymous aggregate, which is wonderful.